Well, good morning, everybody. My name is Bob Brocker. I'm the founder and president of AgeWise Colorado, and I'm joined by Barbara Boyer, our executive director, and our guest this morning is Dr. Huntington Potter, and he's going to talk to us about the latest research and findings and help for Alzheimer's. And what I'm going to do right now is just do a very brief introduction to what we do at AgeWise Colorado and what A Little Help is doing. This is a joint webinar with A Little Help today. So I'm going to flip over here and share my screen for just a couple of minutes, and then I will introduce Dr. Potter. You already know what we're going to be talking about. So that's the first slide. And this is the contact information for myself, Tanya Matthias at A Little Help, and Barbara, who you see on the screen. This is our second joint webinar, actually, with A Little Help, and this is our 46th AgeWise Colorado webinar. We ask everybody to please mute and have your camera off during the presentations, except for our presenter, of course. And we do encourage questions. If you put those in the chat, we may have some time for verbal questions a little bit later. And I'd like to remind you that both AgeWise Colorado and A Little Help provide essential services to help Coloradans age in their own homes. We always like to remind people that you can make a donation. We're both nonprofits, and here are the places to go to see how to do that. And then we also both have volunteer opportunities. Our volunteer opportunities are different than A Little Help's volunteer opportunities. So we're not taking away anything from each other at any point in time. And quickly here, this is what we're doing with AgeWise Colorado. We're here for all older Coloradans today and caregivers of older adults today and tomorrow. So we're a free to use connection. As you can see here, we connect you to vetted service providers, reliable information, and free educational events like today to those 3 million Coloradans over the age of 40. A Little Help is focused on connecting neighbors to help older adults thrive across Colorado. What that typically means is volunteers that provide transportation to medical appointments, grocery store shopping, etc. Friendly visits for people who live alone, and things like yard work and cleaning out a garage and washing windows, things like that. Little Help started about 15 years ago, and I've been involved with them most of that time. Okay, so what I'm going to do now here is read a very, very, very short bio of Dr. Potter. He's the Kurt and Edith von Kaula, I think I'm pronouncing that correctly, Memorial Professor of Neurology at the University of Colorado School of Medicine, Alzheimer's and Cognition Center, and the director of the Alzheimer's Disease Program for the Linda Cernick Institute for Down Syndrome. Dr. Potter is also an esteemed fellow of the American Academy of Science and will bring us up to date today on the latest Alzheimer's research, drug therapies, and clinical trials underway at the UC Anschutz campus. So, Dr. Potter, I will stop sharing, and you may share your screen at any time.
Great. Thank you very much, Bob, for inviting me, and for AgeWise and A Little Help for sponsoring this. And thank you all for coming to this webinar and learning what I can tell you about the latest results in Alzheimer's disease, not only at the CU Anschutz campus, but worldwide. And as Bob said, please do have questions and put them in the chat. And if you have questions that come to you at 3 in the morning, give me an email or whatever, and I will try to get to them. As I sometimes joke, if you read on the web or hear somebody tell you that broccoli cures Alzheimer's disease, first, don't believe them, and second, get hold of us at CU Anschutz. We can set the record straight. So again, welcome, and I will begin to share my screen if I can find the right one to do. I think this is it.
Yes. Work.
And we will put this on the full screen. Everybody can see that, I assume.
Yes.
And so basically, we need treatments for Alzheimer's disease, and we're dedicated to understanding the disease better, understanding its progression. And as many of you probably know, Alzheimer's disease should not be called old-timers disease. It's actually a disease that starts at least 20 years before the first clinical symptoms. And understanding that has led to a better understanding of how we might be able to diagnose the disease earlier and how we may be able to develop treatments. And we will just go here. Here we are. So our University of Colorado Alzheimer's and Cognition Center is dedicated to understanding all kinds of neurodegenerative diseases, such as Alzheimer's disease, and also the understanding of what we would call normal brain aging and how we can develop understanding of that and how it may be different from Alzheimer's disease and how it may also be treatable. So Alzheimer is a German clinician in the early part of the last century who was able to understand a particular patient, August Dieter, shown on the left-hand side there. And what he was able to do was to recognize that this individual had what was then called pre-senile dementia. Pre-senile dementia merely means dementia, confusion with respect to time and place and people, not having short-term memory as we all expect, and sometimes being quite paranoid because they didn't recognize their family or their physicians. You can imagine how scary that must be. But this person was in her 50s. So instead of getting the dementia in a later age, which was somewhat expected, we now understand it shouldn't be expected. It is a disease, but she had it very much earlier. And then what he was able to do when she died was to take a look at her brain and discover a completely new neurological disease, which the head of his institute named Alzheimer's disease for publicity and fundraising and to make a recognition that Dr. Alzheimer had discovered something new. So if you read the original paper in German, it's only a couple of pages long. There are translations, of course. You'll be amazed at how insightful Dr. Alzheimer was and how his description of this disorder really reflects what we know about it today clinically. Now, for many, many, many decades after Alzheimer's discovery, Alzheimer's disease was considered extremely rare. And that's because it was essentially defined into this early onset dementia, which was rare. But in the 1960s, the pathologists, the clinicians, and the biochemists got together and realized that Alzheimer's disease was actually quite common because if you included the people who were getting demented in their 70s and 80s, you take a look at their brains and they looked exactly like the brain of August Dieter. And so now we recognize Alzheimer's disease as a critical public health problem. There are approximately 6 million people with Alzheimer's disease in the United States, tens of millions worldwide. The current cost is over $350 billion a year now in the US alone, and it's expected to rise to about $1 trillion a year by 2050. So we can't really afford that either emotionally or financially, and we absolutely have to understand it better and to develop treatments that could stop and ideally reverse the cognitive decline that affects people with Alzheimer's disease. Now, of course, the reason that has become more common is because we're all living longer, and approximately 10% of people over 65 and maybe 35 or 40% of people over 85 have Alzheimer's disease. It is an equal opportunity disease. It does affect people of color at a greater frequency, and it affects women at a greater frequency. And most important for the studies that our scientists are doing is that it affects 100% of people with Down syndrome. Person who has Down syndrome, 3 copies of chromosome 21, you may recognize them in the community, you may have family members. By the time they're 30 or 40, their brain, if they die for some reason and donate their brain to science, we can see the Alzheimer's pathology in the brains of people with Down syndrome by the time they're 30 or 40. And by the time they're 50 or 60, a very large proportion are demented. Now, you ask, well, is Alzheimer's disease inherited or due to environment? And it's both, actually. But about 60% of the risk is due to genetics. And we'll spend some time today talking about that genetics. And we'll also spend a little time at the end talking about the environmental and lifestyle aspects that can influence whether you are at risk for developing Alzheimer's disease or not. Now, the University of Colorado Alzheimer's and Cognition Center does have a treatment, memory disorders clinic, where we have 9 behavioral neurologists, and 1 is focused on developmental disorders like Down syndrome, a couple of neuropsychologists, social worker, other providers, and we see almost 3,500 patient interactions per year. And that's grown from about 100 a year 10 years ago. So it's a very large memory disorders clinic. And the best that we can do is to give diagnostics and the state-of-the-art treatments, which unfortunately are not yet very effective, and we'll talk about that. And of course, clinical research. All of that is available, but there's a wait list because obviously the number of people in Colorado and the Denver area who may be benefited by this academic medical center is high. But don't lose heart. Get your neurologist to recommend you if they feel this is necessary for your health. So here are the 4 drugs that are currently FDA approved and have been for 20 years that are usually prescribed for anybody who has Alzheimer's disease. Aricept, Razodine, and Exelon are 3 drugs that do the same thing. They help keep an enzyme that destroys a neurotransmitter like acetylcholinesterase from being damaged. And so that means that the neurotransmitter works a little better. The Menda works on another neurotransmitter. And as you know, neurotransmitters are the molecules that the brain nerve cells use to communicate with each other. So these drugs do not really attack Alzheimer's disease directly, but they help the nerve cells communicate with each other a little bit better. And that's all we had until a couple of years ago. So clearly we need more research. And this is a slide that shows some of the people in the laboratory that I'll talk about their research and as the talk goes on. And then the person on the left-hand side you can recognize as having Down syndrome. And she died of Alzheimer's disease, donated her brain to our brain bank, which we very much appreciate. And that's how people can help us with our understanding of Alzheimer's disease and Down syndrome, as I say, which always leads to Alzheimer's disease in the brain. So let's review a little bit the pathology of Alzheimer's disease that Alzheimer himself first described and which we understand in greater detail now. First thing he noticed was the brain of August Dieter was smaller. It had shrunk compared to a typical person of that age. And the main thing that he discovered was some new stains that had just been developed by Dr. Golgi at that time, were the amyloid deposits and the neurofibrillary tangles. So, sorry. If we take a look at these amyloid deposits, which I will do now, is shown here in this very thin section of brain from a person with Alzheimer's disease. And these are called amyloid deposits. They occur outside cells. They're surrounded by a halo of the finger-like projections of nerve cells that are dying. And then this nerve cell has a neurofibrillary tangle inside it and will die. What Alzheimer also noticed was there were fewer neurons, and we now know there are fewer connections between neurons. We call those synapses. And there's a lot of inflammation in the brains of people with Alzheimer's disease that lead to these cells trying to eat up the amyloid and failing, and these cells that are getting activated around these amyloid deposits. So that's led to an understanding that Alzheimer's disease is an inflammatory disease. Okay, so how do we use this to develop a better understanding and treatments for Alzheimer's? Well, what has happened over the last 10, 20 years is that we've recognized that Alzheimer's disease, as I indicated in my introduction, begins probably 20 years before clinical symptoms. So here is an age curve where the plaques in the brains of people with Alzheimer's disease rise even in the period when there's no dementia. And they even reach a maximum before any clinical symptoms are available. And tangles come up a little bit later, and throughout this process, nerve cells die. So here we see that by the time somebody has severe or even moderate Alzheimer's disease, a lot of damage has occurred in the brain already. And we have to understand how that damage leads to nerve cell death and how we may be able to halt it or even, hopefully, reverse it. So what did Alzheimer's see? As I mentioned, here's a normal brain over here on the left, fat and happy, but of course it comes from somebody who donated their brain and died from something. And this is a brain of a person with Alzheimer's disease. You can see it's much smaller. The spaces between the tissue is larger. And these are the plaques and tangles that, as I indicated. Now, a really big molecular breakthrough came in 1984 when two scientists, George Glenner and Kenny Wong, were finally able to identify the protein in these amyloid deposits. And this is now called the A-beta peptide or amyloid beta peptide. And it's shown here, and I promise there won't be a test at the end of the lecture about this sequence of amino acids, but this is the first real molecular breakthrough because this protein is what is killing the nerve cells in this region. And we have to understand why. Now, one of the first questions is, where did it come from? Did it come from a bacterium? Did it come from a virus? Did it come from Mars? Obviously not. But one of the things that was found was that it actually comes from a normal human protein that has other functions, that happens to break into pieces, and this little peptide has the tendency to make these amyloid deposits. So that was the first hint about what was actually going on in Alzheimer's disease brains. And the other thing that was found fairly soon after that was once you get a sequence of a peptide, you can ask where the gene is coming from. And it turns out the gene for the amyloid precursor protein, APP, is on chromosome 21. And that explains why people with Down syndrome all get Alzheimer's disease, because people with Down syndrome all have 3 copies of chromosome 21 instead of 2, like everybody else. And that means they have 3 copies of the Alzheimer precursor protein gene. They make more of it. They make more of the A-beta peptide that is clipped out of the precursor. And that means that they all are going to get amyloid deposits and get Alzheimer's disease. The next breakthrough was when a number of scientists in several places around the world discovered that there were families that had what we call familial or inherited Alzheimer's disease. And here's a family, and the little black dots show people with Alzheimer's disease. And you can see that essentially, if a person has Alzheimer's disease, half their children will have Alzheimer's disease too. and they happen to have a mutation in the APP gene, which gets passed on from generation to generation and gives everyone who has this mutation Alzheimer's disease. Absolutely 100% guaranteed. Now, these families have been collected around the world. There are many families, but it's probably only 2% of Alzheimer's disease that are due to mutations like this. But they give us tremendous insights because it says that the APP gene and its product, the A beta peptide, is really at the very beginning of the process of Alzheimer's disease. And if we could understand what it does and how it gives Alzheimer's disease, like it gives amyloid deposits, then we'll have a way to potentially reverse Alzheimer's disease. Now, this is a summary slide of what we know about the types of Alzheimer's disease and the genetics of Alzheimer's disease. Here's what I've been talking about, the purely genetic form, very rare, early onset. It turns out that August Dieter's slides, their glass slides from Alzheimer's early studies, were found in the basement of his institute, and scientists discovered that August Dieter had one of these familial inherited forms of Alzheimer's disease. And as I indicated, if you inherit that mutation from your father or your mother, you're absolutely guaranteed to get that Alzheimer's disease. So here's the amyloid precursor protein. It's on chromosome 21. Two other genes that this kind of early onset Alzheimer's have been discovered, and they code for enzymes that cut the amyloid peptide out of its precursor. So it all fits together that this amyloid peptide is key. And of course, people with Down syndrome have 3 copies of that gene because they have trisomy 21. So that explains why they get Alzheimer's. But what about all the rest of Alzheimer's disease, the 95% that we call sporadic? It usually occurs in the 60s, 70s, and 80s. As I said, 40% or so of those over 85 have this kind of Alzheimer's disease. And about 60% of the risk for getting that kind of Alzheimer's disease is due to genetics, inheritance. And one of the main inherited genes is called apolipoprotein E4. There are 3 kinds of apolipoprotein proteins, E2, E3, and E4. But E4 is very bad for you for Alzheimer's disease, increases the risk about 3-fold. If you inherit a copy of this variant of apolipoprotein gene from both parents, you have 2 copies, you have about a 15-fold increased risk of developing Alzheimer's disease. Now, there are other genes that also increase the risk, but apolipoprotein E4 is the main one. Now, how are we going to use this information, try to develop new treatments? Well, if you have identified a mutation in a particular family in their APP gene, modern science allows you to take that gene from some blood cells from that patient and put it into a mouse. And now the mouse gets Alzheimer's disease. So they get the amyloid deposit shown here in the thin section of that mouse brain. And that's very valuable because the only other animals that get Alzheimer's disease are monkeys, which are a little bit unethical and very expensive to use in large numbers, and polar bears. And my dean said they didn't want a lot of polar bears running around the medical school. So everywhere in the world, people were developing these mice that develop Alzheimer's disease. By taking a mutant APP gene or a mutant presenilin gene or both, putting them into mice, and then they get these amyloid deposits. And furthermore, the mice have, cognitive problems. They have memory problems. So normally, if you put a mouse into this water maze, this radial arm water maze, they can, with trial and error, find this little glass platform underneath the water and get out of the water. But if they have Alzheimer's disease, if they ever get on the platform by accident or we put them on, they never remember where it is, and we have to rescue them. So here's an assay for developing new drugs for Alzheimer's disease. Can we make the Alzheimer, what we call transgenic mice that carry the human mutant APP gene, can we help them find that platform? So that was what was done, and we now have 2 FDA-approved drugs which are directed at getting rid of the amyloid deposits, both in mice to begin with, and now in humans, and they've been approved because they're very good at getting rid of amyloid deposits, and they're somewhat good at slowing the course of the disease. This is aducanumab and lecanemab, which has just been approved. And basically what they are proteins that have been designed to bind to the amyloid in the brains of people with Alzheimer's and help get rid of it. And they're pretty good at that. The problem is they don't reverse the disease, they slow it a little bit, and they have some serious side effects, which we'll get into. So how do we tell that they are getting rid of amyloid? In the mice, it's easy. We sacrifice the mice, we stain their brain, we can see that the amyloid is gone. But it's possible to see amyloid in a living human being with a special imaging technique called positron emission tomography, or PET. And scientists have made a little molecule that is a little bit radioactive, gets into the brain and binds to the amyloid. And here we see a normal human brain after this amyloid imaging, and they have a little bit of amyloid shown in red, but here's what looks like in an Alzheimer's patient. All that red is amyloid in the brain of that person. So we can actually measure amyloid in a living individual, and when they take one of these anti-amyloid drugs, their amyloid can be removed. And that's very positive, and that's why they're FDA approved. Here's an example. Here's the baseline. 1 year later, with no treatment, the amyloid is still there, but here it is with different dosings, and you can see at the highest dose, the amyloid has completely gone in this individual. Living individual with Alzheimer's disease, started out with amyloid and now has no amyloid. Unfortunately, their disease cognitively is still there. The drug has slowed the decline, but it doesn't actually reverse it. And we're now trying to figure out why that is. Now, the biggest problem with these drugs is that they have a set of side effects which are worrisome. One is brain swelling that can be shown over here, and also some brain bleeding, which is shown over here. And that occurs at the highest dose in some 40% of people taking this drug for aducanumab for Alzheimer's disease. Clinically, it doesn't show up as a bad side effect, but you really wouldn't want brain to be bleeding and swelling in a person with Alzheimer's disease. So that's the fly in the ointment. These drugs are promising, but they're not a magic bullet yet. So we need to try to develop better drugs. And I'm just going to tell you about 3 that we've developed here at CU Anschutz that look promising. They're not FDA approved for Alzheimer's disease yet, but with more work, we hope to go down that road to FDA approval. So remember that apolipoprotein E4 is a genetic risk factor for developing Alzheimer's disease. And we discovered why a few years ago. And it turns out that what ApoE does is it teaches the A beta peptide how to make amyloid, how to stick together and make amyloid. It's a catalyst, we call it chemically. And here's an example of how that was proved. Here's our mouse. And they have a mutant APP gene, so they make lots of the A beta peptide, and they make amyloid deposits in the brain, and they have cognitive deficits. They have memory problems. And here's a sort of a related mouse in which we have genetically removed the ApoE gene completely. It still makes the A beta peptide, but it has no ApoE gene, and now the amyloid is totally absent. It never makes amyloid because it doesn't have the catalyst, the ApoE gene. So A beta peptide is essentially harmless unless it has ApoE to teach it how to make amyloid. And this mouse in that water maze is totally normal. Now, unfortunately, the ApoE is an important gene, an important protein, so we can't just get rid of it in humans the way we can in the mice. But it tells us how to develop a potential drug for Alzheimer's disease. So this is what we did. We took the A beta peptide. We could buy it from a company. They synthesize it. And if we put it in a test tube, it sticks together and makes fibers like we see in the brains of people with Alzheimer's or the mice with Alzheimer's. And those fibers are toxic. They kill nerve cells. If we add ApoE4, this process is speeded up tremendously so that it makes more amyloid fibers and it kills nerve cells. Okay, so that's our assay. We wrote to the NIH in Washington, and we asked for every drug that they could give us that was already FDA approved for human studies. Not Alzheimer drugs. They were drugs for headache and for cancer and for bone marrow stimulation, lots and lots of drugs. And we tried them one at a time to see whether any would block this process. And it turned out that we have 5 so far. We're still looking. And they're very effective at blocking the effect of ApoE4. And the most promising are listed here: imipramine, which is an antidepressant, and olanzapine, an antipsychotic. This just happens to be accidentally what they're FDA approved for, but it has nothing to do with their benefit in this assay. Both of them bind to this ApoE A beta interaction and prevent it from happening. And when we looked in the database of people with Alzheimer's disease who had been prescribed these drugs, those people with Alzheimer's disease got better. Not only did these drugs prevent the pathology in the laboratory, but they actually reversed memory deficits and improved clinical diagnosis in people who had taken them for their normal indications. Now, we also found out that all other antidepressants and antipsychotics had no effect in this process. They didn't make Alzheimer's patients better, and they didn't make the mice and the nerve cells better in the lab. So it's only that these block the ApoE4 A beta interaction. We need a clinical trial to prove that they help people with Alzheimer's because this was a retrospective analysis. We need a clinical trial, and we're trying to raise money to do that. The other thing that we did was to ask, well, we know a lot about people who are at high risk for developing Alzheimer's disease, people with Down syndrome, people who have a mutation in APP or in presenilin, or who have a ApoE4 allele. They're at increased risk. But what if we could find some people who are at decreased risk? Well, it turns out that a number of scientists found that people with rheumatoid arthritis are relatively protected from developing Alzheimer's disease. Now, the idea at the time was we already knew that there was inflammation in the brains of people with Alzheimer's disease. Maybe the fact that people with rheumatoid arthritis are always taking anti-inflammatory drugs for their pain and their swelling and their inflammation in their joints. And of course, when you take a drug, it goes everywhere, and maybe it was blocking the inflammation in the brains of people with rheumatoid arthritis and accidentally keeping them from getting Alzheimer's disease. Great idea. There were some hints in the mice. So a large clinical trial was started to treat people with Alzheimer's disease with anti-inflammatory drugs. And unfortunately, it totally failed. So that wasn't the explanation. We had a slightly different idea, which we pursued, and that was maybe people with rheumatoid arthritis are, in response to their disease, making something that was anti-inflammatory or which was helping them. It wasn't enough to get rid of their rheumatoid arthritis, but maybe it was making it less bad than they would have had it otherwise, and maybe it was protecting them from Alzheimer's. So Tim Boyd, a graduate student of mine, and I started looking for features of rheumatoid arthritis that might explain this protection. And to make a long story short, we found a blood protein called GM-CSF that increased in people with rheumatoid arthritis. And when we injected it into the brains of our mice with Alzheimer's disease, this side got GM-CSF, this side got a control solution with no effect. And you can see that the amyloid deposits were reduced. This is one injection, 1 week later, half the amyloid was gone. Then we discovered by looking in the literature that GM-CSF would cross the blood-brain barrier, so we tried injecting it under the skin of these mice, and it turns out that the mice really became totally normal in this water maze. So here are the errors that the transgenic mice would normally make before they had to be rescued and shown where the platform was. And this is the same mice treated with GM-CSF. You can see that they're even better than a normal mouse. So we've essentially cured Alzheimer's disease in these mice. And it turns out that GM-CSF is a FDA-approved drug, not for Alzheimer's disease, of course. Nobody thought of that, but it stimulates the bone marrow to make more granulocytes and macrophages. That's what its purpose is. Granulocytes and macrophages are special white blood cells that go around the body and eat up things that aren't supposed to be there. And that's why we tried it, because maybe they were eating up the amyloid in the brain. And as you saw in the previous slide, it did eat up the amyloid in the brain, and we even found that it improved cognition. And because it was an FDA-approved drug already, we could ask for permission to try it in people, which we did. And we published that about 1.5 years ago, our first phase 2 trial with the human GM-CSF. And it turns out that the people with Alzheimer's disease that got GM-CSF in this very short-term trial, only 3 weeks of treatment and then a follow-up of 45 days and 90 days later, their memory improved compared to those who got placebo. That's the first time that any drug has shown improvement in memory in people with Alzheimer's disease, and it occurred in only 3 weeks. Furthermore, even 45 days after the end of treatment, in the first follow-up, the people who had gotten GM-CSF injected were better than those who got placebo, salt water. So this was a very promising discovery, and we've now gotten the NIH to fund us for a larger trial, which is ongoing right now. So you say, well, what's going on? And unfortunately, the trial was too small for us to be able to see an effect on the amyloid in the brain. But we could see something, perhaps even more promising, and that was that a protein, which I won't get into in great detail, but it gets leaked out of nerve cells that are dying, and we can measure it in the blood. And it turns out that the people with Alzheimer's disease that had received GM-CSF, sargramostim is its clinical name, actually had lower amounts of UCHL1 in their blood compared to those that got placebo. Now, this is great because this is a measure of nerve cell death in the blood that we can measure in the people with Alzheimer's disease, and GM-CSF reduced that nerve cell death in those patients. So something is going on in the brain, which is a lot better than they started out with. We also discovered that the GM-CSF improves cognition in mice with Down syndrome. These are special mice that don't get Alzheimer's disease, but they have Down syndrome, and the drug improved their cognition. And here are normal wild-type mice, and they even got better in their cognition with GM-CSF. So these are elderly mice. They have cognitive problems just because of age, and GM-CSF improves it to the equivalent of a young mouse. So it improves cognition in basically every mice type that we've tried it on. So again, we've got the hint that the nerve cells don't die in the brains of people with Alzheimer's disease treated with GM-CSF. And when we looked in the mice with Down syndrome that have been treated, we discovered that these nerve cells that are present in normal mice treated just with saline, for instance, these nerve cells are very important for a lot of functions. And in the DP16 mice, which have Down syndrome, they're gone. Those nerve cells just plain don't exist. But when those mice were treated with GM-CSF, pow, those nerve cells come back. And that's the first time anyone has seen nerve cells regrow in mice that have cognitive problems, in this case, Down syndrome. And that turns out to be true in the mice and the rats with Alzheimer's disease. So all of this has encouraged the NIH to give us money to do GM-CSF trials in people for a longer time, 6 months in this case, 5 weeks in people with Down syndrome. Those have all been approved by the FDA as a trial, approved by the IRB, and we've started screening people and treating people. We hope in a few years to know whether GM-CSF really benefits people with Alzheimer's or with Down syndrome. Now, this is all very exciting, but you remember this finding here where we saw that the nerve cell death is reduced in Alzheimer's patients with treating with GM-CSF. Well, we asked, what is this cell death? Is it only in Alzheimer's disease, or is it occur during normal aging? And we've recently found out that it does occur during normal aging, even starting at age 2. This nerve cell measure of damage increases. It increases worse and worse and worse as you get older. And this treatment with GM-CSF reduces that nerve cell death to the equivalent of a young child. So it essentially stops the nerve cell death in these AD patients. Doesn't just reduce it, it stops it completely. So that's very exciting as a treatment for brain aging and for Alzheimer's disease. We just have a lot more work to do. And we'll see how it works out in these 2 clinical trials. Now, I've talked about genetics and I've talked about treatments, and all of that is going to give us a great hope for getting a treatment for Alzheimer's disease. But remember that only about 60% of Alzheimer's disease is due to genetics. The rest of Alzheimer's disease is influenced by environmental risk factors. So while you're waiting for the FDA to approve these new drugs and improve them, you also know that there's something you can do about the risk for Alzheimer's disease right now. And these are listed here. So increasing the risk of Alzheimer's disease is high blood pressure, stroke, and high cholesterol. It's a good idea to keep your cholesterol down, excuse me, and reduce your high blood pressure. That's going to help you with risk for stroke and also risk for Alzheimer's. Smoking increases the risk of Alzheimer's about 2-fold. Stop. It will help you a great deal, in addition to helping you with potential for stroke. So smoking's not good. Type 2 diabetes increases the risk of Alzheimer's about 2-fold. Take your drugs, do all the right things for reducing your type 2 diabetes. Low educational attainment increases the risk of Alzheimer's disease. So keep coming to these, age webinars that you can get educational stimulation. That's a good thing. And keep your weight down, because high BMI in midlife is a risk for Alzheimer's disease. Now, if you want to decrease your risk, exercise, exercise, exercise. It's good for the heart, it's good for the brain, and there's nothing bad about it, except in, of course, certain people who can't exercise. You have to be careful about that. And caffeine seems to decrease the risk of Alzheimer's disease in the mice and in people, and we're going to be looking into that more clearly. As I indicated, cognitive coming to this age-wise webinars, that's a good thing to do in various aspects of cognitive activity. Now, if you go and try to get better at Sudoku, there's no evidence that that in particular is helping with Alzheimer's disease. It helps you get better at the game, but I'm talking about general cognitive activity is helpful. We have a big team at the University of Colorado Alzheimer's and Cognition Center. We have clinicians, we have scientists, we have scientist clinicians, and we have a lot of people that are behind all the data that I shared with you today. And we're particularly appreciative of the research participants and their families that take part in these clinical trials, because without them, we couldn't translate the work that we see in mice into humans. And finally, philanthropists that have made donations to the trial efforts and the preclinical efforts, and the funding agents such as the NIH in Washington and the Alzheimer's Association. Again, without their help, we couldn't do any of this work. And we hope that the University of Colorado will be where the cure for Alzheimer's disease will be found. We have great ideas, we have great scientists and clinicians, and keep in touch. Our next year's webinar may give even more exciting results. So thank you very much for coming, and I'm very glad to answer any questions that may be in the chat. I see only one chat, so see.
I don't see anything in the chat yet, but I have a question.
Sure.
You mentioned earlier the possibility of being tested. Can you talk a little bit more about that?
Yes. So for a long time, it's been possible to find out whether you carried the ApoE4 allele. And you can do that with 23andMe, for instance. And the problem is that it's not clear what you should do if you are ApoE4 positive. So scientists composed an experiment. They took a large number of people who had a family history of Alzheimer's disease or were otherwise at potential risk, and they tested them for ApoE4. And then they divided the people into two groups. One group they told their ApoE4 status, and the other group they didn't tell. And what they were concerned about was, if somebody knows that they're at risk for Alzheimer's disease because they're ApoE4 positive, will they get depressed? Will they run off and marry the milkman and spend all their money on trips to Las Vegas? No, that's not what they did. They started to lose weight. They got their cholesterol down. They got more exercise. They ate better. So they did everything they could do to reduce the risk of Alzheimer's disease and counter the effect of ApoE4. So that's a good thing. It's not a bad thing to learn that you're ApoE4. So what I recommend is that everybody should pretend that they're ApoE4 positive. And I honestly don't know whether I'm ApoE4 positive or not. And I recommend that you do all the good things that you're supposed to do anyway, as though you were ApoE4 positive. Now, the blood tests for Alzheimer's disease, such as the tests for brain damage in the brain, tests for A-beta peptide in the brain, those are now developed for research purposes only. They're not something that can guarantee a single individual whether they're at higher risk for Alzheimer's disease or not. They're a population study and a research study. So they're not quite ready for clinical assessment. But that will come within a year or two, I expect. And hopefully in a year or two, we'll also have better treatments. So that's a good question, Bob, and got a complicated answer, which is that scientists are working on these blood tests and other tests, but they're not quite ready for prime time.
Okay, thank you, doctor. We have a question here about, is there any effect of a plant-based diet on Alzheimer's disease?
There's no evidence that any specific diet, vegan or plant-based, is better for Alzheimer's disease. But what we do know is that the Mediterranean or the DASH diet with low animal fat, more vegetables, cutting down on sugar, for instance, all of these can reduce the risk of Alzheimer's disease.
Okay. And the follow-up question here was, can one sign up to see if eligible to be a research participant? How does that work?
Absolutely. If you go to our website, there'll be a click to be able to ask about participation in research. And there are, of course, a long list of things that make you eligible or not eligible for all the various clinical trials that are in the neurology department. But you can find that out, and maybe you'll be eligible. I can tell you that one of the problems with all Alzheimer's research is that people who have dementia may not have Alzheimer's disease, or they may have Alzheimer's disease plus, say, vascular dementia, or Lewy body dementia, or frontal temporal dementia. And the essence of clinical trials is to focus on testing a drug which is targeted specifically to one kind of disease. If a person has dementia due to another disease or mixed dementia, then it gets very confusing to scientists to see how to interpret the results of a clinical trial. So there's a whole set of questions and assays that need to be done before somebody's deemed to be eligible for a clinical trial. But it's worth doing, and we very, very much appreciate people volunteering for these studies.
Another question. What are the side effects visible if the usage of this drug is effective within 2 years?
Well, it depends upon the drug. So far, the side effects in the aducanumab and lecanemab are the brain bleeding and the brain swelling. And they don't have obvious clinical manifestations, but they definitely are not good for the brain. So it's generally recommended that people with ApoE4 do not take these drugs. But of course, 66% of people with Alzheimer's disease are ApoE4 positive. So it reduces the number that would be recommended for these drugs. Now, for leukine or GM-CSF, we saw no ARIAs whatsoever in the 3-week trial. And we haven't seen any so far in the longer trial. So that's promising, that's hopeful. And we'll just have to see whether some of the other drugs coming along have these side effects or not.
Well, I think it's pretty remarkable what you've done, so far. I mean, there's a lot more hope than there was a year ago, 2 years ago.
Oh, okay.
We are very hopeful, but we have a lot more work to do before it can be declared to be a success. And of course, part of the reason for that is that we are primarily looking for safety right now, plus efficacy. And suppose that we discover that 5% of people get significantly worse for reasons that would have to be discovered, and 95% of people get better. The FDA wouldn't necessarily like that. We would have to be able to identify those that are at risk for getting worse and those that may be responders, as they say, and get better. So that's why clinical research is so complicated and so expensive.
And I'm confused. Can participants that qualify for test studies be harmed in any way? I guess you sort of answered that, but maybe a little elaboration.
Well, one of the things that we are very careful about in recruiting people into clinical trials is to make sure that they do not have any comorbid problems such as serious heart disease or active cancer that give them make them automatically at risk for mortality or morbidity. And we certainly don't want to include them in the trial in case the drug has a worse effect on them than it does on everybody else. So we're very careful to take people who are otherwise very healthy. They just have Alzheimer's disease. And that can only be determined by long questionnaires and blood tests and brain imaging to make sure that we have the best people for the trial that aren't going to be harmed. So you're very wise to bring that up.
And so from what I'm hearing you describe about dementia and its other forms, then there is a possibility, well, not a possibility. I mean, you can sort out, for example, Lewy body dementia from Alzheimer's, and that all takes place sort of routinely now, I guess. Is that correct? Yeah.
Well, it's not routine in the community.
Okay.
A primary care physician can't tell the difference. Even a trained neurologist can often not tell the difference. There are very subtle cognitive tests that have to be made and imaging that have to be made to tell the difference between frontal temporal dementia and Alzheimer's disease, just as an example. So that's why for these clinical trials, we have trained behavioral neurologists and radiologists who to take a look at people and determine whether their dementia is due to pure Alzheimer's disease or not. Good question.
Hello?
Yes, go ahead.
I've been diagnosed with, I'm a physician, I've been diagnosed with MCD. I've been on Aricept, a small dose of Aricept, and I would like to join your study. How do we do that?
Well, the best thing to do is to go on our website and at neurology, and they will have a click for participation in research. If you have any problems, give me an email and I'll find out exactly how you can sign up for being considered. And certainly the fact that you're on Aricept is not going to keep you from being on the study.
Well, I'm willing to stop that, so that's not a
Oh,
problem.
no, we don't want you to do any stopping. We want you just to stay the way you are. As long as it's physician approved and you've been on it for a while, it's much better than stopping, because then that, twists everything around in a new way that we don't have prediction about.
And your site is at CU Anschluss?
Correct.
Great. Thank you so much, and good luck with your studies.
Well, and good luck to you too.
Thank you so much.
So, Dr. Potter or Rich, I know Richard is on here too. Maybe one of you could put into the chat your website address and any contact information that you care to share. That would be great.
Great. Thank you.
Yeah, the other thing I should say to Dr. Fetterman is that if you only have MCI, then you wouldn't be eligible anyway, because you have to have mild to moderate AD to be eligible for the trial. And the reason for that is simple. Some people with MCI get better naturally, and some people with MCI get worse naturally. And so we really need people who are clearly not going to get better on their own, so that we can see the effect of the drug.
Well, this lady doesn't know if I'm getting better or not. So how's that? How's that?
Well, she may know better than a clinician.
Okay. Thank you so much.
Appreciate it. Thank you.
Hey, real quick before we all go, I just like to give JJ Jordan just a little bit of time, because I know she works very closely with Dr. Potter to talk about her work in the area of dementia here in Colorado. So JJ, you can speak up.
Thank you. Hi, Dr. Potter. I had coffee with Dr. Potter this morning. Did we not? We did. I think you're on mute, Dr. Potter.
Sorry. Yes, it was a great coffee or tea, and we
Thank
thought
you.
about the potential benefits of caffeine as we sat there.
Yes, we did. So thank you. This was a wonderful talk as always. My name is JJ Jordan. I'm the community chair for Dementia Friendly Denver. That's part of Dementia Friendly America. And we do talks all the time called Alzheimer's Dementia 101. And I just wanted to, I'll put this in the chat, but I just wanted to give you all my email. It's dementiafriendlycolorado@gmail.com. And if you'll email me, I will let you know when the next public talk is coming up. And I know Dr. Potter would love you all to come and learn even more in an hour, hour and a half. Although we learned a lot today, and I appreciate that so much, Dr. Potter. So I'll put that in the chat. If anyone's interested, just reach out to me and I'll make sure you get an invitation to my next talk. Thanks, Bob, for the opportunity to say that.
You're very welcome. And thanks for being on today. Now, Dr. Potter, do you have any closing remarks, or it looks like we might have one more message. Let's see. Are there any age restrictions taking the treatment?
Okay, so for people with Down syndrome, that trial is adults up to age 35. For the Leukein GM-CSF trial for Alzheimer's disease, of course, we need them to have Alzheimer's disease, so a 12-year-old would not be appropriate. We might be able to think about 12-year-olds who have Down syndrome later on, but it's too early to do that right now. The other thing I would say that I sort of hinted at in the last slide, and that is that the study of Alzheimer's disease is not only a matter of scientists going into the lab and testing things on mice, and then eventually doing a clinical trial. It's really a community collaboration, because without the community helping us with donations and with volunteering, then we couldn't do our treatment. So scientists love to collaborate with other scientists, but we also love to collaborate with community members. And I just want to thank you all for coming and getting the word out yourself after hearing what JJ or myself have to say.
Okay, well, thank you so much once again, and we really appreciate your time and knowledge and being willing to share that with us this morning. And so we will invite you back next year and see what the progress has been. We'll look forward to that too. Okay, well, thank you everyone for being on the call today, and please let your friends and neighbors know that about this, and we'll be posting this recording on our website probably within the next few days. And so it'll be available, and anybody can take a look at it, share the link with whomever. So that will be just fine. Okay, well, have a great day, everyone, and thank you all once again.
And thank you, Bob.
All right, bye-bye.